So welcome everyone out there in virtual land. Welcome to the Leadership Summit and the last session for today, Thursday, which is titled Peer Preferred Treatment Outcomes. I'm Phyllis Foxworth and I serve as the Advocacy Vice President for DBSA. I hope this is going to be a very interesting and informative session. During the first half of the session, we'll share with you what we've learned from the peer community about how they describe and define wellness and preferred treatment outcomes. Then this is going to be followed by a discussion with Kimberly Allen, a prominent peer in the community, and Dr. Ray DiPaolo, a well-respected clinician and researcher. So we'll be sure to leave lots of time at the end of the session so Kimberly and Dr. DiPaolo can answer your questions. You can put those into the chat and we will leave time at the end to get to those. So just for those of you who don't know, we are, in order to make this session as interactive as possible out there in our virtual world, we'll be using Slido. And this is going to give you the opportunity to share your insights throughout the session. If you know how to scan the QR code, you can do that now. You can scan the QR code that's on the screen. If you would prefer, you can go to slido.com. And if you do, you'll see a screen that looks like the one that's shown here. And then just please enter the word Advocacy Track, no spaces, in the blue box that's at the top. The arrow is pointing to that. That says joining as a participant, enter code here. So just type in Advocacy Track. So in this session, you're going to have the opportunity to provide short answers to questions. So for that reason, if you may also decide to go to slido.com instead of the QR code, if you prefer typing on a keyboard rather than your mobile device. So whether you're using the QR code or slido.com, the next thing you see is a list of days and times. And these are all in Central Time. So it is 5 o'clock Central Time here in Chicago, where this is broadcasting from. And again, my name is Phyllis Foxworth. So you're going to want to select Thursday from the list and the time that it is here in Chicago, which is 5 o'clock. So then after you've selected today's date and time, you can check at the top of the screen to see that you're the correct day and time by looking at the top of the screen. It should say Thursday at 5 o'clock. Again, which is the time it is in Chicago, depending on where you're calling from. You can also go to that spot and change it if you accidentally click the wrong time. All right, so to begin our discussion, it's important to understand how the healthcare system measures treatment outcomes. So for this session, we're going to review 3 major contributors. The first we'll discuss are the medical product developers. So when designing clinical trials to prove the safety and efficacy of a new product, they must choose an outcome they believe that patients will achieve in the clinical trial. So then when submitting a new application to the FDA for approval, they need to demonstrate that the product achieved those results. And they need to be using a tool or scale that the FDA recognizes as an acceptable tool for measuring treatment outcomes. The second major contributor are clinicians. When participating in mental health treatment with a clinical team, the clinicians use a set of accepted measurements or tools to understand if the patient they are treating is making progress. And then finally today, the third pair that we're going to talk about in the ecosystem are our third-party payers. And so these organizations have influence over whether a patient can participate in a treatment modality. For example, whether that's a pharmaceutical intervention, inpatient or partial hospitalization programs, or talk therapy. They too use existing accepted set of measurement tools or scales when they're making decisions on whether to reimburse the provider or the health plan subscriber. But what's most important to understand about these instruments or scales that are used in measuring treatment outcomes is that they're typically focused on reducing the symptoms of the mood disorder. So DBSA has heard from the community that symptom mitigation is not the most important treatment outcome they are seeking. And a reduction in symptoms is not necessarily how they define wellness. So as a result of this insight, DBSA initiated the Transforming the Definition of Wellness for People Living with Mood Disorders program. We initiated this 5 years ago to begin asking the important question, are we measuring the treatment outcomes that are important to peers? So we took a 3-step approach to collect the peer input on their preferred treatment outcomes. The first was to commission the Supporting Wellness Survey in 2018. Then this survey was used as the foundation for a DBSA-led patient-focused drug development meeting. This is an FDA program that collects input directly from patients about the unmet need of a health condition and to hear directly from patients about the treatment outcomes that they are seeking. So then, based on input from the first 2 approaches, we made the decision to conduct focus groups in 2019. So with all of these different methods of collecting and hearing from the patient community, we learned a lot. So what did we learn? To begin, let me share how peers experience living with a mood disorder. We learned from the focus groups that peers often experience it as a chronic condition. They go through up and down cycles, often within the same 24-hour period. These cycles are manifested through feelings of not being in control of one's feelings or environment. Focus groups participants express that they feel a fog in their brain that can interfere with the ability to complete tasks of daily living. And they expressed overall feelings of exhaustion, both mentally and physically. The idea of chronicity came out in the Supporting Wellness Survey. 73% reported they experienced persistent symptoms or had had 10 or more discrete periods of symptoms throughout their life. 69% reflected that they first started experiencing symptoms before age 17. And more than half predicted their own personal definition of wellness could change more than once within a 24-hour period. We learned from the patient-focused drug development meeting that living with a mood disorder can interfere with the natural progression of life events. Academic pursuits are delayed or are never completed. We heard over and over again about the concept of underemployment. Peers shared that they were unable to reach their full potential professionally. So, not surprising, if academic goals and professional potential are not achieved, financial stability is compromised. And we also learned that relationships can be destroyed or go unrecognized. We learned from both the survey and the PFDD meeting that mood disorders and whole health go hand in hand. 44% of survey respondents stated that their overall health was worse since experiencing symptoms. In a different survey conducted by DBSA a year earlier in 2017, we learned that 51% of those respondents stated that the impact on their overall health was a reason for not taking medication. Many of the focus group participants shared that self-medicating led to substance use. Overall, we heard in both the PFDD meeting and the focus groups that achieving an adequate pharmaceutical response can be a very frustrating journey of trial and error. It was important for us to understand how peers define wellness in order to understand how they identified and prioritized treatment outcomes. We heard from the focus group participants that their symptoms are chronic, but that a good day is not necessarily the absence of symptoms, but rather the ability to have a sense of stability throughout the day in spite of those symptoms. 91% of the respondents to the Supporting Wellness Survey stated that their goal in life is to function as well as possible. 83% stated they think in terms of how well they function at work, play, and connect with others. Our focus group participants told us they experience wellness as being able to keep up with daily routines and activities. A common theme among the focus group participants was how much they prioritize self-awareness about their symptoms and having the ability to deploy coping tools in spite of their symptoms. So they knew they would experience symptoms, but a good day was being able to maintain control of their emotions and connections with others in spite of their symptoms. So in order to know if current tools are measuring what's important to peers, it's important to understand how peers define whether or not they're making progress towards wellness. We learned that peers define wellness in terms of productivity, positive relationships, and the intensity of negative thoughts. So now I want to hear from the audience out here. So please go to your Slido and just type in a word or two, not a long sentence or a paragraph, but just a word or two that describes how you define wellness. All right, we'll give a couple of seconds, a minute here or so for people to start. How do you define wellness? So I think they're showing up in the chat, but they're not showing up. There we go. Now they're showing up in the chat. We have attending to my overall well-being, functionality. And this is a word cloud. So it's showing us what is most common, what it's seen most out there. We're getting some others. Comfortable with oneself. Stability seems to be a more popular response. Okay, so that's very valuable for us to know. Functionality, great. That's good to see that the people have been able to start using the Slido. I want to introduce our panel now because I want you to think about what I just shared with you about the impact of the condition on your overall well-being and what kind of treatment options you're seeking. And most importantly, how do you define wellness? So I'm going to stop my share and introduce can we spotlight Kimberly and Dr. DiPaolo now? Are we able to put all three of us up there? Yeah, great. So as I said, I want to continue this discussion with our panelists. I'd like to welcome Kimberly Allen and Dr. Ray DiPaolo. Both Kimberly and Dr. DiPaolo have worked with DBSA on our Transforming Wellness for many, many years. Dr. DiPaolo serves on the Transforming Wellness steering team, and he represents the clinician point of view. He is a University Distinguished Service Professor and co-director at the Johns Hopkins Mood Disorder Center, and he's a chairperson of the National Network of Depression Centers. Kimberly Allen, hello Kimberly, is a peer who has been with us on the Transforming the Wellness journey from the very beginning. Thanks, Kimberly. She served on the advisory panel that provided guidance on developing the Supporting Wellness Survey. So the survey that we can, it's been almost 3 years now. She's a global mental health advocate, and a principal with Blue Eye Consulting. So welcome, Kimberly and Dr. DiPaolo. So Kimberly, let me ask you first. Peers tell us that they're seeking relief from the impact these conditions and disorders have on their lives, especially around school, work, and relationships with others. So Kimberly, you live with bipolar disorder. What treatment outcomes have you in the past or currently seeking with regards to school, work, or play?
That's a really good question. And hello, everyone. And one of the words I most heard was the word impact. The impact. You know, it's hard to talk about the impact, isn't it? But I was inspired by hearing other speakers in the summit talk about impact. But when I look at outcomes on recovery from this, you know, initially, the very first time I ever went in the hospital, I had managed to get sober because I had some really serious behavioral symptoms. And by that, I mean, I was alcohol dependent at a very young age. I had very serious bulimia that went on for a number of years. So when I looked at outcomes early on, I was admitted the first time for 32 days under major depressive disorder. And that shows you back in the 1980s that we could actually do that. Our benefit plans actually allowed us to go inpatient, if you can imagine that, for 32 days for MDD, major depressive disorder. But, you know, I look back on my treatment outcomes. I tell you, to speak honestly, I wanted to be in the upright position. I wanted to be alive. I wanted to be in the upright position. I could see my father dying of this illness, and he had exactly the symptoms that I did in terms of alcohol. They put me on lithium almost immediately. And I remember I felt like I was standing on a rocking boat at that time. Now, this was the 1980s. So when you're talking to a kid my age at that time, I was in my 20s. And, you know, back in the day, I got sober pretty early. But the bulimia really had me in a stranglehold. So that was, I was all about that early on, is reducing these behavioral symptoms and getting up and on my feet. Little did I know that the other things would happen, Phyllis, and I can go into that, but the financial impact was unbelievable once I got out. That's when my problems really began. And I think you're muted. Yeah.
Yeah, I was. This is the interesting thing about doing virtual presentations. There was a fire truck going by, so I muted myself.
Chicago, yep.
But that's because I live in the city of Chicago. So how as you move through your life, what has been the impact on things around work, play, and with others?
Goodness gracious. You know, I look back on that. When I got out, I was nice and solidly depressed for a decade. A decade went by. It was a trial and error decade. And I tell you, the impact of that was isolation, loneliness, and fear, really despair. And this was while being sober. And you know, when you get sober, you don't want to feel like what I just said. So that level of despair impacted my ability to work. And this was really a shock to me because I was trained to work hard. I was set to work hard. I was all prepared to be my PhD. I wanted to work for Dr. DiPaolo. You know what I mean? I really wanted academic excellence because that's the kind of person I am. I'm still like that. So when I realized that I resultantly from going to treatment 3 more times, declared personal bankruptcy at the age of 26, and I worked in a hardware store, I worked in a sandwich shop, I did many things. I'm exceedingly proud of that, of all the things that I just said, but declaring personal bankruptcy, the impact of that was an erosion of my self-confidence. And resultantly, I felt as though I couldn't marry. I felt like an economic burden. I looked at myself in the mirror and I lost my dad, and then I got cancer. So when that happened, when I saw myself in the mirror, I thought to myself, who is this person? So it impacted everything that I just said. And I became isolated because I didn't want anyone to know about it. So it impacted me, Phyllis, in every way that you named on the PowerPoint. And I did have all the things that came after that. When I came up out of my depression, I got very, very active, very short fuse, and very unpredictable at that time. Went to jail a couple of times, I might add. Don't do that.
Right. Well, Dr. DiPaolo, let me ask you, I'm going to go back to something that I saw that I shared in the presentation. that 91% of the respondents stated their goal was to function as well as possible. And I think, Kimberly alluded to some of that as well, that you said, I wanted to get a PhD. Yet 66% of the respondents said my healthcare team is strongly focused on symptoms. So when working with patients, how do you uncover the impact of the mood disorder that the mood disorder has had on their lives?
Well, I thanks for the question, and I'm delighted to be here. I've been very fortunate to be able to work with patients in groups as well as individually. But I would say that, how do you discover it? Basically, the phrase we would use now is you got to get to know your patient, get to know their life, the life that they have lived before they got ill, if there's enough of that there, and depending on their age, but also the life that they intended to live. I mean, a patient of ours who was in the hospital for a long time, and when he got out, I didn't see him for a very long time, but he got his degree in filmmaking and made a film. And we screened the film here at Hopkins about 10 years after he was in the hospital. And one of the other patients asked him, how long did it take you to get back to being the person you thought you were supposed to become? And he said, oh my gosh, that took a very, very long time. So his symptoms were under control, or otherwise he couldn't have gone to school and gotten the education he needed, right? So symptoms are important. If we're not getting those helped, we're not getting very far at all. But that's not, what we all want. I mean, actually, when you think about it, even for any of us in academics, we often go to bed at night, maybe feeling mad or not mad or whatever, but that's not what we think about right away. What we think about is, did I get it done? I might be mad, but it may be because I still have a little bit of mad on because I persuaded, the dean to make a bigger investment in depression, right? It's okay to be mad then because it's kind of a good mad, right? Whenever I would put in a grant, I would be prepared to be rejected because that happens so often, and I can still remember the first time I got my first grant. And I was happy, but I was still mad. I knew I was going to get mad. I still got mad anyway. It took me 5 days to realize I had it, but the most important thing, this is talking about me, the most important thing is get to know my patient. The life they have, the life they intend to have, the life their parents had, the life of the other people they know, so we can get a feel for that. And in fact, I love that. That's why I love working with students too, I want to know what it is you really wanted to be doing.
Yeah.
By the way, I will add one other thing, and that is, though, that work, that is that work itself, though, is therapeutic. And so when I have somebody go home, and especially a mother, working mother, and the husband says, okay, here are the kids, honey, I'll see you later. I go, no, don't do that. She needs to be able to go to work because she can feel like she accomplished something during the day, et cetera.
Right. I'm going to ask our audience a question. Let me go back to sharing here. And I just realized that it doesn't pick up where it left off. All right, are you seeing that now? Yes. So my question to the audience is, do you think it's important to communicate the impact of your mood disorder to your care team? So that's a pretty simple yes or no question there, folks. So it looks like there isn't anybody who's answered that as in the negative. Well, let me follow that up then with another question then. So then how do you, and this is for the audience, how do you ensure your care team is aware of the impact? And this is, you can type, this is not a 1 or 2 word, you have the opportunity to type a sentence here. So go ahead, we'd be curious to know how it is that you make sure your care team is aware of the impact of your mood disorder. Should we have the Jeopardy music playing? Do we have people answering the question? Or is it just taking that long to show up? Oh, here we go. We're getting some responses. Okay, so some people use a health app. Trust. That's an interesting word there, trust. Share with whom I'm comfortable with. Again, another talks about using a health app. So Kimberly, you've lived in recovery for quite some time, and you've had access to clinical care at different points in your journey. how do you define recovery for yourself? I'm going to stop the share screen here for a moment and get back to you. How do you define recovery for yourself, and what role does your clinical care team play in helping you achieve those goals?
Well, you're looking at my recovery right this red hot second, and this is what it means to me. You know, we are connected. We are connected. I'm not isolated. I'm with you, no matter where you're calling in this country or outside of it. Connection, no social isolation. You know, just like animals, you know, we survive together. That's the sign language for the word family. It looks like this, together. You know, so recovery for me is doing something meaningful. I'm doing it in this moment. You know, I happen to be a boxer. I box about 3 days a week. You know, boxing equal being calm and relaxed and consistent and determined and courageous and suiting up and showing up, you know, just, and besides that, I enjoy it. It's cool. Being in recovery, it's cool to be in recovery. You know, I've always been cool and I want to be cool now. I'm 62 years old. And to me, what that means is that I'm unique. All of us are unique and I'm exceptional. So every day I wake up in the morning, and being in recovery means this to me. You know, I take my meds without being invited to. I used to call my partner the Pope of medication because she would drop it in my hand. You know, I walk my dog on my own. I read poetry. And Dr. DePaulo has given me some remarkable things to read, and I'm so pleased to have read those. And DBSA, you know, I fly the flag of DBSA because to me, what it means is we're all part of this collective effort. And I couldn't be happier to be a part of this initiative. The other thing I'm going to do, to be honest, is brain endowment. I'm leaving my brain. And you know why? Because I'm into it and I'm not mad at it and I don't want to hurt it, you know? So I'm totally intrigued alongside with DBSA, with Dr. DePaulo, and with all the peers out there on how fascinating we are. And one time Dr. DePaulo said that he likes us, and I was like, yay, because we're interesting. So that's recovery to me. I'm excited, I'm participatory, and I'm motivated.
So let me ask you then, you know, what role did your clinical care team, you have got this great recovery that I've known you for many, many years, Kimberly, and I've always admired, you know, your abilities to stay in living in wellness. What has been the role of your clinical care team? How did they help you get there, and how are they continuing to help you?
Well, thank you for that question. It's a great one. I've had many clinicians over the years. Some of them I had to really invite to help me because it really wasn't happening. They were overly confident in the medication they were assigning me, and I could see them pulling in the yoke. I was even in treatment with some healthcare providers, prescribers that had had death by suicide with patients, you know, so I could see them trying, you know, but I had to invite them to understand and to hear my voice that I meant what I was saying. I meant what I was saying. In other words, I just kept it up, kept it up, kept it up. And here's what they did for me. And thank you to my clinical teams because, you know, I've got the luxury of having a clinical team, unlike some of my colleagues on the Cape of Africa. You know, so here's what they do. They're my coach because I demand that. I'm an ex-professional athlete. I always have a coach. So if I hold my handle, I was a pro water skier. We said, don't throw your handle. So there were times I've been drugged behind a boat and I've been drugged behind this illness, but I asked that care team to keep their eyes on me. I asked them for a report card. I asked them to tell me how I'm doing. And I asked them to be exceptional with me. So they're my coach. They're my coach. When I walk in, I ask for feedback, and I typically have a list of questions in my hand. And I got to say that I've got some good coaches in my corner right now because they remind me of what I'm doing right, and they're assets based, and they help manage me as a patient. I've had some other providers that are no longer with me. We had a parting of the ways. And all that means is they may have done something that didn't work for me. So I asked them to remember what I'm talking about, to remember what I'm focused on. So I love it when I walk in and they say, hey, Kimberly, how's your boxing? Or they say, Kimberly, how's your marriage? Are you communicating? And I can say, yes, sir. Yes, ma'am, I surely am. So we have a very specific relationship and I'm very vocal. DBSA has made me a little more vocal than I was before.
Well, it sounds like that you take ownership of your well-being and communicate with your clinical care team. These are what the goals and treatment the treatment outcomes that I am seeking. Is that a correct statement?
There's no doubt about it. And like I told you, I track them, and DVSA has a lot of tools to help me track those that we didn't have back in the day. So yes, I absolutely track specifically with those goals as written by me. And then they have their goals for me, and we pull in the yoke. We do it together.
Right.
Yeah. You know, Dr. DiPaolo, I've known you for a long time as well. And you've shared with me that you have had the patients that you've worked with for many, many years. Have you, recognized that through the time that you're working, that their goals have changed over time? And how do you recognize that?
Well, I mean, I hope it's because we're asking each other those things.
Mm-hmm.
But yes, it is true. I do see patients' goals change over time. And I think our goals for our patients change over time. They've got to, because, life is always changing. And the question is, where can we get now? What's okay, we're here, and what can we do? I think but I was struck, I have to admit, I was very struck by the initial response on the screen as I don't feel comfortable telling my treatment team about the impact of my illness. And I feel very strongly about that. That's very common amongst the patients I know. And so I know I've got to win their confidence that they can tell me these things. And in fact, I often will try to give them examples about that. I had one of the things I try to tell people, for example, is I always tell them that I don't have a blood test to tell me how you're doing. I depend on you. Okay. Mm-hmm. Now, when I was a young psychiatrist, I often made the mistake of seeing very early improvement that I could see in the patient's movement and their responsiveness, but that they couldn't feel yet. They still felt like, death warmed over. Sorry. But, and I can remember I would get very encouraged, and even slapped a couple of my patients on the back as they came in the door. Boy, you look so good. And they looked at me like I was crazy. And until I figured out, wait a second, that's what comes before the improvement. And I like to tell patients that too, because often their family members will tell them, oh, you're looking better now. So I just want to get to all those things. And that is to say that, first off, I want to know what the impact is. I've sometimes got to tell patients that. By the way, I have assertive patients too, like Kimberly. And most of the time, that's wonderful. It makes my job easier. On the other hand, occasionally they might have an idea that I don't agree with, for example, and we got to fuss that through. We got to figure that out. So one of the things that's really important for me, and I also think I learned with experience, didn't know it intuitively, is that, look, there's so much we do not know about this illness, okay? And we don't know exactly how the causes happen. And therefore, we don't know really, as you all know, I see this from some of the other things you've said in the survey, you all picked up on this, is that we don't know why our treatments really work when they work, and that is our medical treatments. And we don't know why they fail when they fail. We also know they fail too often, and they work too slowly when they work. We've got to be in this together. Kimberly's got that right. We are all in this together. I was supposedly an expert in this illness before I realized it was in my family too. So my family members could teach me things too. I had an aunt who had been in a nursing home for many years, and everybody thought she had schizophrenia. But I asked her sister, my aunt, who was 80 years old at the time, what is she like when she's ill? And she said, well, she's really bad. She stays in bed all the time. I said, well, what's she like when she's well? And she said, well, she runs the gift shop at the nursing home when she's well. I said, well, wait a second, that doesn't sound like schizophrenia. And she says, yeah, and how can you tell when she's getting sick again? And this time they described mania. And she said, well, she's like Teddy Roosevelt charging up San Juan Hill, Mm-hmm. But like a lot of people, she had to find her own solutions. And unfortunately, they were not always the right solutions. She had gotten addicted to amphetamines, things like that, because they would at least make her feel like she was alive. So everybody's life is different. Their goals do change. Hopefully they get better and better. I mean, in one sense, now I can go to work. I think I've told you guys the story of my first patient, who, when I first saw him, he was sort of the accountant in an auto theft ring. Okay. And literally. And, but as he got a little better and, would come in the hospital, learn more about his illness, he then ended up becoming a shoe salesman and That was better, not totally satisfying to him, but it was better. He got married, had some children, and then he became a drug and alcohol counselor. So yeah, his goals in life changed. And it wasn't until about 3 or 4 admissions into his treatment that he said, "Hey, Dr. DiPaolo, what was that you said before? Maybe it's time for me to think about that, seriously." So
Right.
hang in there is what I would say, and understand that, and I think it's important to know we don't know everything by any stretch of the imagination. But what we do know is important, I like to say, but what we don't know is crucial also.
Right.
That's why we've got to focus on research as well.
Right. This conversation has been really interesting to me in that, we started talking about that individuals are telling us that symptom mitigation is not necessarily what they're looking for. And what I've heard from you, both of you, is, this emphasis on achieving the things that I want to achieve in my life, and working with your patients to help them find what they want to achieve in life. But I would be curious for both of you. Do you find that sometimes there is a step back, where symptoms do become important because it's the symptoms it's a full circle. It's like, now I'm back to experiencing symptoms, and the symptoms are keeping me from doing the things that I want to do in life. And, Kimberly, have you had that experience?
Oh my gosh, yes. About 8 or 9 years ago, it took me a long time to get my master's degree. I did not get that PhD, but I did get my master's degree, but it took me a long time, and I wound up getting a job. I quit making sandwiches and things like that, and I became a treatment administrator. I ran a substance use disorder treatment organization, and I got licensed, and I know a lot about the healthcare business. So I kind of went into the business side of this business, but there came a time where I stopped taking my medication. Now, I know that surprises you, so hang on to your seat, but that happened. Okay, now, my psychiatrist just retired last week. I'm really going to miss him. And his parting words to me were, remember what I said, take your medication. Will you give me your word? And I said, I thank you for being a good man. These were, and we've been together for a while. Okay, well, when I stopped taking my medication, I cannot even quite explain, and I don't think I have to the people in the audience that live with this illness. I got very, very ill, very, very ill. It didn't take very long. I really was not open at all to anyone's suggestions about medication. I was not open at all to anyone's input because I found myself to be a remarkably successful individual at that time. I'm kind of laughing at myself here because I can't lose my sense of humor with this illness. I refuse to lose my sense of humor with this illness, and that's what I call those. I call them my sense of humor failures. I had a very, very significant sense of humor failure across the board. Now, if I would have been in the field of addiction treatment, I would have said that I would have required some form of intervention. What's very interesting for me to think back on is I was surrounded by clinicians at that time, and I became very, very ill. So to anyone hearing this, I required help. I required help. I'll go back to my boxing analogy. I need a corner man. I need a corner woman. I need someone in my corner telling me the truth. I need someone pointing this out. Now, I'm very, very fortunate that I did wind up getting married, and that was who had to come forward, my spouse, and say, hey, you are not well. And I really was offended by that. Very, very offended by that. Bone crunching depression, though, caught up with me. Bone crunching depression, I was no longer in the upright position. And I mean that literally. And it was very, very scary. So when we talk about impact, I needed to communicate my fear about that. I didn't want anyone to know. I didn't want my clinician to know. I didn't want to disappoint my prescriber. I didn't want to be wrong. I didn't want my partner to know. I just had a huge shame spiral. You know what I mean? So here's what I think. And our keynote spoke to it yesterday. The candor to admit that my identity was a mistake on my end. I am not a mistake. I am not a mistake, but it really was a crisis of identity. And I live with this every day. This is my current treatment outcome I'm all about, I'm not who I thought I was. I'm not, and that's okay. But I did have to call my prescriber, and I did have to say, wow, I'm not who I thought I was. It really is true. And Phyllis, you know, at DBSA, this has happened with me. I can't travel well necessarily. I can't get under super high stress because it really eats me up. Then I can't drive because I'm too anxious. And then I won't eat because I think a lot of things, you know? So that prescriber had to get in there and coach me, get on the bench with me. And I had to have help to get to treatment. And I got there, and I was there for 31 days, and that was straight out of pocket. And I'm sorry to say that, but I knew that I had a lot of thinking to do in the desert. And I did do that. And I thank God that my partner came and visited me, because everybody needs someone to empathy just to wipe the sweat from my brow. And then I came home again, and my prescriber and I had a conversation, and I had to say, you know, you were right and I was wrong, and I need to make some significant lifestyle changes. And that wasn't easy. But I did
well, you know, I want to open this week up for some questions from the audience, because I'm sure they probably have some questions. But Ray, I think that, you know, one final question for you is that, you know, Kimberly has shared how, you know, that symptoms can come back. How do you recognize that with, you know, in patients that, and she talked about how thankful she was that she had this long-term relationship. How do you, you know, approach that with your, with the patients that you're working with, that we've been working on your goals, which were not symptom-based, but now it's kind of like, let's get back and focus on some symptoms.
Right. Well, let me tell you, but first I want to say, first off, I'm glad we're focusing on that too, because they all fit. They just fit in different parts of the puzzle. So we need to know the symptom scores and all that stuff. And but often it's always an interpretation. In other words, we all have moods. We all have days when we have more energy and less energy. And so you've got to kind of listen and read between the lines a little bit, if you can, sometimes. And mania is quite different. Mania is quite different than depression. Actually, one of my patients I loved so much, she and her husband both passed away now, but he was the salt of the earth, wonderful guy. And when she would get a little bit manic, and she could control it when she would come in the office because she knew I was going to be watching. But she had this absolute repeated line, his name was Bill. Dr. DiPaolo, Bill is at it again. You know, he's just bothering me all the time. You know, what? Doesn't want me to do this, doesn't want me to do that. And then we get Bill in, and he'd say, yeah, I want her to settle down. She's gonna wear herself out. You know, she's trying to do 18 things at once, right? But it was always Bill. Bill's at it again. So relationships are important. On the depression side, though, it happens like that too. It's just different, because what happens is that doesn't just affect your energy and you slow down and you don't have the energy, but also you interpret it differently, because it doesn't just affect your energy. It affects how you actually view yourself, as you've commented on. And that's actually in some ways the most painful part of the depression, is that it makes you feel like you're a failure. This is my fault. And sometimes patients conclude, it's not depression, doctor. You know, you've given me the pills. It's me. You know, I've got a personality disorder, they might say, okay, or something like that. Mm-hmm. And I go, well, wait a second. I've seen you well, you know, and I think we should judge your personality when you're well, but I don't think that's where you are. But family are very important. I've seen one of the comments in the chat session. My husband has been my rock. I was diagnosed when we were married 15 years ago. That is, if you've got that, that's wonderful, especially if you can listen to them and hear them. That doesn't mean they're always right, because the person on the outside won't see the whole thing. Never does. When patients get about 70% well, their spouses often think, well, that's it. They're back to themselves now. But on the inside, they may still be feeling like, I'm terrible, I'm a failure. And even when their symptoms seem to be gone, sometimes patients are just totally obsessed with, it's going to happen again. It's going to happen again, doctor. And I kind of feel like that's kind of at least a little bit of depression right there sometimes. So, you know, and none of us are perfect on knowing, well, when it's the disease and when it's a little bit of me being worried, right? So
right.
You just got to keep sifting.
We got a couple of minutes to take some questions. I've got a question here. It says, I have trouble knowing what to tell my psychiatrist when I speak to her. And I am currently doing therapy, but I have felt that I probably should. Oh, I'm currently not in therapy. I have struggled with therapy as well, because I feel I am paying a lot of money. Do you have any advice on how I can take a proactive response on my care? And also, are there doctors that are better at pulling things out of you, so to speak? Well, that's a good question for both of you.
Right. They're better. Yeah. There are patients that are better at expressing it. There are doctors that are better at drawing it out of you. Hopefully doctors get better with time. I mean, I for myself, I think I'm better than I used to be. Okay. So I used to judge people by how they look. Yeah, go ahead.
So we should go to older doctors?
Yeah, well, maybe. Therapists especially, though. I think, I do think experience really changes me as a therapist. And I like to I do, quote unquote, my version of therapy. Many of my patients need something a little more sophisticated than what I do. And so I'm delighted that they want to do more if they can. But by the way, it's hard enough to find anybody to treat you, be a therapist or a doctor these days. And our insurance situation and everything else is really quite a challenge.
Right. Hey, Andrew, do we have other questions in there?
There are a lot of things in the chat. You might look in the chat section.
In the chat? Okay.
I've been monitoring the chat and I haven't seen any questions come through.
Okay. Because maybe I'm not monitoring the chat well enough.
Yeah.
And participants, you can also, we have another question.
Okay.
Have you ever used role playing?
For me, probably not not in a kind of transparent way. Sometimes I think in one sense, well, I might say, somebody will present a plan to me. Like I'm going to get divorced next week, or I'm quitting my job. Okay. And I might kind of start talking to them like I was, their employment coach, things like that. Are you sure? What are you going to do next? Why? That sort of thing. I will say that I do encourage people not to make major life decisions when they're in the middle of a depression, or really in the middle of a mania, probably even worse, right?
Right.
But when they're in manic, I'm not very persuasive with manic patients, right? When they're really extremely manic, right, they are going to do what they're going to do to a certain extent. And that's when they need something to help them rein that in, right?
So I'm going to share the screen one last time before we leave, because I do want to hear from the audience again. And I found that it doesn't necessarily share the way I think it will, but let's see. Whoops, I stopped share. Hang on. Share. And let's do this question. So let's go.
All right, I'll look at that, yeah.
Overall, we'd love to know, this has been a wonderful discussion about the journey, about symptoms versus functionality, what are treatment goals. I'd love to hear from the audience, what word or word best describes how you know you are making progress in your wellness journey? I think that would be a really great way to end our conversation today, is to understand from you, how do you know you're making progress?
While we're waiting, we know that's going to take a minute for that to come up. Oh, joy, there we go.
What you were going to say, Ray, while that was coming up?
While we were waiting for that to come up, is that patients often will tell me, I'm better now. And then 2 weeks later, will say, well, I thought I was really better, but now I'm really better. Mm-hmm. And, you kind of want to keep going. Also, by the way, better is also sometimes is fewer side effects even for my treatments. I think about my patients who get ECT for their bad depression. And 2 weeks later, they'll say my memory's better, but I know 4 to 6 weeks later, it'll be a lot better than that.
Yeah. Let me see if there's any responses in the
That's great. Look, this is good.
Mm-hmm. Feeling less exhausted. Yeah. Yeah. Others, how do you know you're making progress? And are you communicating that to your care team that you're making progress? And what are because I think that, Ray, that's something that you've shared upon, is that, if I know that, what are these, not just the symptoms of the disorder, but what is the attributes and characteristics of progress, then that helps you put the whole puzzle together.
Sure. Yep. Well, this is great. These are responses that make a lot of sense to me. I like this one, the tone of yourself feels upright. Mm-hmm. And my resident, I was doing supervision yesterday, and one of my residents told me about his patient who successively has told him each 2 weeks, now that we've got the lithium level right, I can feel like this is the real me.
Yeah.
And those are key moments.
Right. I feel at peace. I mean, that's a sign of progress for one person. So, go ahead, Ray, go ahead.
No, one individual also shared in the chat, I've learned my triggers. And we also do have another question regarding, can you speak more to the point about how you share about the impact of your mood disorder with your care team?
Okay, Kimberly, can you take that one?
Yes, how I share the impact. You know, I use real words like the word despair. That word, no one should feel despair. So say it like it is, you know, and I use something that's memorable, you know, that my provider can actually relate to, because, you know, and I speak a lot to hope. I want to have a hope, because when I say don't throw your handle, here's what it means to me. Even when I'm having symptoms, I need to have hope. So if I feel hopeless, boy, I tell you, I told them right away. One thing I learned very recently, during COVID, I had 3 of the worst days I've ever had, and since I've had this mental health condition. And I use the words that DVSA uses. I live with this mental health condition. I refuse to die of this mental health condition, but I do live with it. Now, during those 3 days, I was visited by every dark visitor that I've ever known. It reminded me of Charles Dickens, where the children of despair and all of that climb under the skirt. And boy, I tell you what, I called the doctor and I said that. I said, look, these raggedy children are my own. We're either going to name them, you know, but we're going to talk about it, because they're sitting in my lap with me. So, you know, if I need to use, don't be afraid. You know, if I need to use language like what I just said, that doesn't mean I'm delusional. And that does not mean I'm hallucinating. It means that I'm telling you a story that has words that hurt, because I'm hurting at that time. And like I said, wipe the sweat from my brow. I'm not asking for instant relief, you know, for, let's say, an injection or a pill that gives me relief within 2 weeks. But what I am saying is, hey, sit with me here so that I have hope through this night. And that's what I asked from that coach. And you know what? I've had a really good response. You know, the last thing that I'll tell you is, a lot of times people meet me and they think I have a tiger by the tail. I don't have a tiger by the tail. It makes me laugh. But what I do have is hope. And if you don't have the ability or wherewithal to have a prescriber like I do, or if you don't have or can't afford a therapist, then you sit down on the bench and you talk to somebody. And I've got a little bench by my house. There's seniors that walk their dog by it. And I sit on that bench and I say, hello, hello. And they turn around and they wave their hand at me. And I think to myself, today is not the day. I'm going to be like that guy. I'm going to be like that woman. I'm going to walk my dog when I'm that age. And we're giving each other hope with no exchange between us, except saying, how are you?
Yep. Yeah. Dr. DiPaolo, I'll give you the last word here.
I just think Kimberly's amazing. That's my last word, is that, and I love patients that work with people like Kimberly. That doesn't mean that Kimberly's, as she said, she gets the ideas right sometimes, she gets the ideas wrong sometimes, but she says what's on her mind, so I don't worry about that. That's good. I do want to encourage my other patients to try to put it into words. It's hard sometimes to put it into words. You don't know the right words, and moods are hard to put into words sometimes. So, but no, I tell your doctors, if you're not happy with what they're doing, tell them. I used to have I had a patient once who was afraid to get a second opinion. And I remember I kind of kidded her, and I just said, well, look, do you pay your bills? And she said, yes. And I said, you pay your bills, and the doctor goes home at night and you're worried about him. I said, come on. He's got 1,000 ways to do that. But we've all got to know, and I've had my patients actually either ask for second opinions. I've certainly told many of my patients I want them to get a second opinion. So speak your mind. Don't worry about being wrong. Okay. And have a discussion. So, but Kimberly's, she's the tops.
Yeah. Well, you guys have been a wonderful audience. Thank you for sharing, your insights and thoughts with us. It's made for a really wonderful discussion with Dr. DiPaolo and Kimberly Allen. I want to thank you so much for giving your time this evening and sharing your insights with our audience. So at that, we will conclude. So thank you, everyone.